Well, it looks like we got a good group formed. I'm gonna, kick us off with just some context on the series we've been hosting, and then we'll, move and get into our panels. Yeah, so as many of you know, this webinar is the second of 3 webinars we are hosting on substance use in Massachusetts. And we're doing this now because the substance use crisis, obviously continues. It's evolving as ever and poses new challenges for our communities. And while there are many examples of communities and organizations helping people recover and saving lives, we're still losing thousands of people each year to addiction, overdose, and despair. So this struggle continues, and MAPC, as an entity serving our cities and towns, we're invested in building community capacity to prevent substance use disorders and help the people suffering from them. At our last session in January, we looked at where we are at this point as a state in the crisis. We learned about the stories of loved ones lost that have motivated people to take action to prevent more people from being harmed by substance abuse. We looked at the latest data on SUDS in Massachusetts, and we learned about prevention programming offered by DPH and what medical treatment looks like for people suffering from SUDS, and especially young people. So today we wanted to move forward and talk about challenges and solutions and hear from people in community health, social service agencies, and local governments who have been providing a mix of services to support people with substance use disorders to access housing, treatment, medical assistance, and other supports. I know, probably for all of us, it feels like this crisis is insurmountable, but every life saved, every person helped is a triumph. And there are good systems and strategies being deployed across our state that are making a difference. And from challenges and solutions today, we're gonna have a third session on March 8th, where we will discuss kind of the agenda ahead. What more needs to be done to address this crisis and what funding and resources are needed to do it. So we have a great panel today, and I'll briefly introduce who they are and their roles and the work they do, and then we'll turn it over to the panel from there. And we will be taking, throughout, we'll be taking questions in the chat. We might not be able to get to all of them, but we will be taking questions in the chat. And once the panelists have kind of done their kind of initial roundtable, we will try to see if we can have some of those answered. So feel free, once we get going, to put questions in the chat. So our panel today is going to be moderated by Penny Funio. She is the Prevention and Outreach Manager for the City of Medford and has been a great partner to many people in this field and also to MAPC. We're also joined on the panel by Dan Cortez. He's the Community Engagement Specialist for the Chelsea Police Department and has played a really leading role in setting up Chelsea's wraparound services and outreach programs. He's joined by a key partner in the work being done in Chelsea. That's Gladys Agneta. She's the program director for Chelsea Substance Use Disorder Mobile Outreach Program. And she is, works for Community Action Programs Inner City, which is an anti-poverty agency in Chelsea. We're also joined by Keith Wales, the Director of Homeless and Outreach Programs for Elliott Community Health Services. And I think, he'll have a lot to share about the amazing work they're doing to help unsheltered populations and people with substance use, move into, stable housing and benefit from other services. And then Amy Bositis is joined as well. She's the Clinical Service Director for the Greater Lawrence Family Health Center and can speak about the experience of supporting people with SUDS, from the health center perspective. So without further ado, I'll turn it over to Penny and we will get going with our panel. Thanks, everyone.
Thank you, Mark. Thank you to MAPC for asking me to moderate this panel. It's truly a privilege. So I'm Penelope Funioli, Prevention Outreach Manager for the City of Medford. I've, in my position, was established in 2015, and it's a city-funded position, which is very rare in the field of prevention. I'm sure some of you are snickering in your heads right now about that, but to invest in prevention is to invest in the future. And my privilege has been the ability to do both prevention and outreach. And what I've learned through my work here in doing that is that youth, which is the focus of prevention, and people who are seeking to obtain recovery are seeking the same things. And that's what the effort of these fields are trying to do: create personal empowerment, a focus on health and wellness, and healthy relationships. These two things come together almost seamlessly when you look at the intention and the purpose of what we're trying to do. So when we hear the complicated factors that come in building an outreach program, and we think about the complication of positive youth development and how to communicate that to a community. The other key thing that I've noticed in my career is that by addressing stigma, we've started to really create an understanding that substance use disorders is a disorder. It is something that needs to be treated as such. It is not moral. It is not behavioral failings of an individual. And we're getting that on the side of outreach. We're getting police and fire and EMS and officials to understand that this is a disorder. But what we need to realize is when we're building our prevention, that young people making behavioral mistakes doesn't indicate that they have moral or whatever belief. So as we start learning to bring these two fields of work together, and we use the strength of prevention, which is planning, assessment, it's capacity building within the community. Capacity building means understanding the problem too, right? Not just the infrastructure of professional networks. So I'm excited to speak to some of the folks here on the call today on the panel. I've worked with some of them very, very closely, and they've done just tremendous work with me collegially. I've been able to do a lot of great work in this city because of their partnerships. So without further ado, I'm going to first call on Dan Cortez. And the question that we want to know is, can you tell us, introduce yourself and the work that you do as it relates to substance use response and prevention in Massachusetts? And then I'm going to go to Amy after Dan. Thank you.
Thanks, Benny. So my name is Dan Cortez. I'm the community engagement specialist for the Chelsea Police Department. It's also a budgeted line item was created in 2015. I spent 2 years prior at Mass General working on a coalition, typical monthly coalition centered around the opiate crisis at the time. And in 2015, I came on board as community engagement specialist to continue that work, but also to coordinate our brand new Chelsea Hub model that was initially started in Canada. And so what I do in my role, officially and unofficially, is I help to coordinate and support a lot of the initiatives that resulted, for example, our Navigator program. Gladys will talk more about the Catholic wraparound services, and then also facilitate the hub meetings, and also support 2 other weekly situation tables that are designed to quickly respond, quickly triage problems that are happening in our state.
Amy.
Good morning, folks. I'm Amy Bositis. I'm the Director of Clinical Programs at Greater Lawrence Family Health Center. I just want to tell you a little bit about what we do here in Lawrence to prevent and treat substance use. As a community health center, we provide treatment for individuals with substance use. But in the last 5 years, we've really expanded from offering just office-based addiction treatment to offering anywhere somebody is substance use treatment. So we have expanded into our local hospital and fund an addiction doc there with all sorts of services to help somebody who's in addiction while they're in the hospital, and then we bridge them to outpatient care. We work closely with our House of Corrections so that when somebody is coming out, we get a phone call and right away outreach the individual and start them on medications. We have, since 2017, had a mobile health unit that has been treating individuals with substance use. And we have that in Lawrence and Haverhill, and provide about 40 hours a week of low barrier, easy access addiction treatment. We also go to individuals' homes after they have overdosed. This is in relationship with our Lawrence Hub. We get the list of individuals who have overdosed, and then we outreach them. We have some recovery coaches, we have nurses, we have docs. We have a team of individuals who are committed to meeting people where they are, providing harm low barrier harm reduction services to people with addiction. And I will say probably one of the centers of our services is our syringe service program, which is an infectious disease prevention program where we distribute and collect clean primarily injection equipment, injection and smoking equipment as an opportunity to engage people in conversations about prevention, treatment, and recovery.
Thank you, Amy. I'm going to go to Gladys and then to Keith.
Good morning, everyone. My name is Gladys Agnetta. I'm the program director at CAPIC's Substance Use Disorders Program and the Mobile Outreach. I also manage the Sela Resource Center, which is the basement of a church that opened back several years ago to be able to provide breakfast, lunch, and showers for the homeless and those that, are in need of, finding a place during the day to relax, enjoy a warm meal, and so forth. Working for CAPIC is a nonprofit organization, and the program, the wraparound services came about through the Navigator program, which is funded by the City of Chelsea. I work closely with the Chelsea Navigators, who are employees of North Suffolk. And I work closely with the Chelsea Police Department. The wraparound services, we provide sober living, transportation, food gift cards, stipend. We have a stipend program, and we also have basic needs. Again, this is all funded through the City of Chelsea for individuals within the City of Chelsea. Doesn't mean that if someone is in need of detox and comes and we encounter them out on the streets or at the resource center or whatnot, that we're going to turn them away from going to detox. Absolutely not. We will provide a cab voucher, whatever needs to get that person to detox to get the services that they need. Obviously, if they're from another city, we encourage that they contact the city that they're from to be able to then get further services if they're available. But that's kind of basically what we do.
Thanks, Keith.
Hi, good morning, everybody. My name is Keith Wales. I oversee homeless and outreach services for Elliott Community Human Services. I've been with that organization for 16 years now, and I've had the pleasure of, I have to acknowledge Dan Cortez and Penny and Gladys, who I've had the pleasure of collaborating with and learning from over the years. And Amy, it's wonderful to meet you. I'm here. We have a lot of acronyms in homeless services. There's a running joke at Elliott that I actually oversee acronyms, but I won't go into all of those. I'm here to talk mostly about low threshold housing, pre-tenancy and tenancy sustaining supports, mostly out of the work that we've been doing for the last 2 years out at Mass and Cass, where we've housed 156 individuals with robust in-home multidisciplinary support services with a less than 2% eviction rate, and our new low threshold housing project in Lynn, which is going very well. And I look forward to talking about those pieces today.
Great, thank you everyone so much. So I'm going to go to you first, Amy, on this question. What prompted the creation of the services that you lead? Do you have any specific stories that you want to share with us?
Yeah, thanks, Penny. I think there's two important motivators for why we do and how we do what we do. The first is my own personal experience was that in 2016 in Lawrence and in Lowell, there was an outbreak of HIV. It reached national attention, and it impacted in the 1 to 200 individuals who were newly diagnosed with HIV. And that was driven by injection drug use. And that was when things really came into focus for us, because we realized that the drugs on the street were very different than what we had been experiencing years before. Fentanyl came to the Lawrence Lowell area in 2012-ish, and that started to change our epidemic. And so we began a lot of programmatic stuff, but I think that's when the overdose and the injecting habits in our communities really came into focus for us. And we started to implement a different way of doing substance use care. Up until then, we were, as most people, sort of a 3 strikes and you're out type of substance use treatment. We wanted to treat you, but we wanted you to follow our rules. And then we started to hear stories and see that the drug supply was actually making that impossible for people. And fentanyl is just a very different beast than heroin is. And so we started to really examine and listen to our patients. And that's when and of course, look at data. Our overdose rates were skyrocketing from about 2012 to about 2016. They were really higher than the state's average. And so as we were dealing with the loss of people's lives in our communities, listening to their stories and seeing what was happening on the streets, we realized we needed to change what we did. And we really started to embrace, as hard as it was for many of us, what we call harm reduction. I'm sure many of you on the call understand this. If you don't, a real brief explanation of it is that harm reduction is a philosophy, it's a form of care that tries to meet people where they are. While holding people accountable for their actions, understands that individuals are the drivers of their own future and that we are here as support for them. And we will tailor our programs and our activities to meet people where they are. And so we started to change our programs and provide care with as few barriers as we possibly could. And that means all sorts of things to us. It means we are not doing drug screens in the same way that we used to do drug screens. It means we take care to where people are. Our mobile health unit is probably our clearest example. We do not necessarily expect somebody to come into our environment, particularly if you're withdrawing or you're using drugs. You might not feel comfortable in a medical community where we have ostracized and stigmatized and make things very structured. And so we try to bring our services to individuals. We do a lot of street outreach. Our docs, our nurses, our community health workers go out, they look for people and they try to deliver care in an environment where somebody else feels safe. So our personal experience of the HIV epidemic and then the stories and the loss in our community of overdoses, I think, Penny, is kind of the drivers and of how we're doing what we're doing right now.
Thank you so much. So I'm going to go to Keith next, and then I'm going to look to Dan and Gladys as a team. So I know you two are working very closely together. So Keith.
Oh, sure. So what we essentially have done at Mass and Cass over the last 2 years was we've been working under the umbrella of an initiative in Boston called Street to Home, which is overseen by the city's Department of Neighborhood Development, and as well as an agency out of Houston, Texas called Clutch. They're a consulting firm. And we went through a process a couple years ago of doing what's called coordinated entry, or CE. So coordinated entry assessments, it's basically an assessment that quantifies your behavioral health complexity, your medical needs, duration of homelessness, risk factors like HIV, domestic violence, commercial sex trafficking, all these different things. And then it spits out a score at the end that's basically used to match the person with a subsidized housing opportunity. So we went through a process where we sort of circumvented coordinated entry, and we had a couple hundred subsidized housing opportunities that came through, and we matched 200 individuals between Pine Street, Home Start, and St. Francis House. And so if you really want to get into the weeds on what our division does, I mean, I mentioned a lot of different acronyms, but the common denominator that runs through all these different service elements is that we identify, deconstruct, and address clinical and systemic barriers to housing and long-term sustained recovery. And that looks differently for everybody. And we acknowledge that, we work with a lot of folks that may not ever make the choice to abstain from substance use. And we're not here to tell people what to do. We're there to just, we really believe in a housing first ethos. You don't have to be sober first. You don't have to stop using first. You don't have to start taking, medications first. But so we started outreaching at Mass and Cass last summer, and very intensively and strategically. So we wanted to reach people that were actually residing there as opposed to maybe staying there or going there for other purposes. So we would go and outreach at 6 o'clock in the morning to find folks. And we did more than 200 coordinated entry assessments, got people matched up to subsidies, and we've housed more than 156 at this point. And a lot of folks have gone through our project, our transitional low threshold site on the grounds of the Shattuck Cottages. So that, I don't know if you've seen anything in the news about the pallet shelter site, but Elliott has a subcontract with an organization called Commonwealth Care Alliance, where we do all the behavioral health, the recovery coaching, the housing navigation, and the post tenancy stabilization work. We just had a milestone at the cottages recently. We've housed our 50th person. And what we did very intentionally and strategically was to take folks that, for lack of a better phrase, were low-hanging fruit to house, meaning they had a subsidy in hand, a viable housing pathway. They had all their vital documents. And so we placed those unsheltered individuals at that site first. And that's what I think has led to the being able to house so many folks out of there. In terms of post-tenancy supports, we're working a lot with accountable care organizations on things to address complex care needs, like in-home primary care, wound care, occupational physical therapy. We're leveraging nutritional counseling, actual meal delivery, harm reduction supplies, Narcan, clean needles. And we believe in, drawing the distinction between the practical and the transformational case management, meaning that the practical part of case management is, we want to make sure this person's paying their bills. We want to make sure that they're, getting along with neighbors okay, and have a microwave and all these mechanical things. But the transformational part that, we're trying to build a life with folks. Not many people have ever come to me in counseling and said, Keith, I'd like to decrease my maladaptive tendencies by 30% this quarter. Like, most of the time people want, to reconnect with family and kids. They want to fall in love. They want to get their GED. They want to work. They want to get gym memberships. And we pay for all sorts of things. We pay for fishing licenses, art supplies. We help people get into choirs. We help people get in any kind of thing that helps folks carve out a life. Because a lot of times when we're housing folks, the elation of getting housed quickly dissipates into isolation and reliving past traumas. And there's not that inherent distraction on a daily basis of where am I going to go to the bathroom? How am I going to eat today? Oh, I got to get to that shelter by 4 o'clock today. And once you're alone, that's when some dicey stuff can happen, and that's where we really want to be there for our folks. Sorry if I went a little over on that.
Sounds like you have an amazing amount of information to share. So we're glad to hear it. Dan.
So I think a lot of you, or especially for those of you that are familiar with Chelsea, and I can speak of only 2013 because starting in 2013, because that's when I started working here in the city. Our problems were very, very visible. Just like right now, there's a lot of attention on Mass and Cass. Our downtown, really, the whole entire city was like a mini Mass and Cass. So there were people everywhere using drugs, people everywhere using drinking alcohol. It was just it was chaotic. We would arrest people, they would be released by the courts. It was like the Flintstones. I mean, nothing was sticking. And I remember visiting MGH Health Center in Charlestown, and they had a person, Shannon Lundeen, that some of you may know, who was not Shannon White, who was a navigator, right? And so I came back to our coalition and to our city manager saying, hey, we need 2 of these folks, because what she's doing in Charlestown is amazing. She's in recovery. She knows everybody there. She's out on the street all the time. Everybody comes to her. She was like a 1-person resource team and a resource center. And so it was very difficult to do, but the city decided to finally fund a contract with North Suffolk Mental Health Association to hire 2 navigators, and their job is also in recovery. Their job is to be out on the streets finding people. What happened is that we started to slowly get people into treatment, but then they would get out and there was nothing there for them, so they would just go back to their normal environment. That's when Catholic and one of our city councilors decided that we needed wraparound services, which is something that we had been talking about. And so they went from city council reluctantly funding to now them saying, we also need this, because success was evident, right? And so one by one, we were, in the minds of the residents and the city leaders, we were navigating people back to their responsive environments, which is other cities, right? Which is not what Madison Cass is doing. So the wraparound services and Gladys can talk more about that, was the second thing that we did. Right around that time, or a little bit before wraparound services, we started the Hub, which is a collection of service providers that take a look at individuals that are being introduced that are facing complex risk factors, and teams are mobilized or created and mobilized to go out and intervene with as a team, because you are then sharing information about that individual. So our problems were, again, very visible. We were ranked #1 in the state for violent crime. There was a lack of perception of safety in the city. We were ranked 11th in the country in violent crime, and since then we're out of the top 100 and we're around 20th, 23rd in the state. And Gladys, if you can talk a little bit more about your wraparound services.
So like Dan said, first it started with the navigators, and they found the need for, instead of just going to detox and then back to the streets and so forth, that they needed the wraparound services. And so they came up, with the budget, the city, and we broke it down into sober living, transportation, like I said, food vouchers or gift card, stipend, and basic needs. But so I was hired, and I quickly learned that one person providing the wraparound service was not going to work. So we quickly, within like a few months, we hired a couple of individuals. And what we did was we hired individuals that were in recovery to help, because their voices also, they knew the places where they could get help. They had already been out on the streets. They were familiar with other individuals out there, and they were our voices of how we could help. We would offer, what we do, we continue to still do, is they go to detox. We don't force anybody, of course, but we continue to see them out on the streets, and we had to build relationships and trust with these individuals, because they looked at us like, okay, what is it? Why are you trying to push us? We're not ready, etc. But once we were out there, we started making connections with Healthy Streets as well. And Healthy Streets is under the umbrella of Health Innovations, and they provide, harm reduction. So we would go out on the streets one night a week, and we had the van, we had clothing, we had toiletries, etc. Stuff that we were able to provide for these individuals that were on the street. Building a relationship with them, they eventually started trusting and coming and seeking assistance. And then eventually going into detox. We would then, once they finished detox and went into further treatment, which we encourage for them to get further treatment. Once they were done with that, we would work with the caseworkers there to then try to get them into a sober living situation. And then, of course, coming off the streets and from detox, they weren't going to be able to pay for sober living. So we would pay up to 3 months, but we also wanted to make sure that they were working on their recovery, like going to treatment, going to their mental health if they needed, going to their doctors, dentists, being able to also seek employment. Of course, there were some glitches along the way because, criminal backgrounds, warrants, etc. So then the staff grew a little bit because we needed some sort of case management work to be able to provide this. We just couldn't let them do it on their own. They needed the support. We provide transportation to detox, from detox if they needed, to the sober living, obviously, and if they needed transportation, we also provided that for their doctor's appointments, etc. Obviously, COVID hit, and then it became a thing where we couldn't get everybody in the van and so forth. So we provide taxi vouchers to get them to where they need to go. Food vouchers is gift cards that we give them for Market Basket, Dunkin' Donuts. We've gotten creative through today is actually 7 years since the program started and since I actually started in this position. And like I said, we've gotten creative with like the food gift cards, because a lot of individuals that were on the streets, we couldn't, like, if we gave them Market Basket cards, yeah, they could get the ready-made food, but they couldn't buy other foods and store it anywhere. So we started buying Dunkin' Donuts cards, Burger King, McDonald's, things that would help them get food when they were out there on the streets. Then we went to the stipend program. So the stipend program allowed individuals who were seeking employment but weren't really getting jobs. We were able to provide them with a few hours a week to work with us, work either at the church, helping serve food, helping individuals who needed towels for showers, cleaning the tables, coming to the office and working here with us with, within the office needs. So, and that program still continues as well. And then providing basic needs when they come into a sober living, they don't always have the toiletries, they don't always have a pillow, they don't always have sheets. So we depend a lot on the funding to get them these things. And also people donate. We get a lot of donations from churches and so forth. And every now and then we put on Facebook that we're looking for like socks and toothpaste and toothbrushes, etc. I've had friends who work in the dental and they've provided us with, toothpaste, toothbrushes, etc. So we provide those to the individuals. We work very closely with the Chelsea Police Department, the navigators. Lately, with Elliot as well, we've now started working very closely with Bay Cove, who has a community center that houses individuals in need. And right now it's single men there. And we still continue the relationship with Healthy Streets.
Thank you so much, everyone. Gladys, thank you. You've led us to our next conversation. And in my work early on in my career in youth substance use prevention, right? We always used to say about our youth, nothing about us without us, right? Utilizing that term to really bring and lift up youth voices into shaping the prevention programming that we have, that we needed to create. For me, this was just the whole thing broke open for me when I started managing the Massachusetts Opioid Abuse Prevention Collaborative Grant for 6 communities in the Mystic Valley Public Health Coalition region. And the state had told us in our grant that we needed to get key stakeholders involved. And one of those key stakeholders were those most affected by the substance use. We had an active user focus group, and it was literally life-changing, right? The participants were sweet, they were funny, they were kind to each other, but they had a lot of stories that were really hard to hear. And they also told us a lot about how they got there, right? And how that progression of substance use was cultural. That progression of substance use was sort of instilled in them. It was a part of their bonding, that they were coming together and they needed an anchor point, and the substance use was that thing early on for them. So Massachusetts as a whole, whoever has been participating in that grant program for 9 years, really was centering those voices. And all of the work that we're doing, a lot of it is shaped by the people who were most affected. And that is an excellent, cool thing that the state of Massachusetts should be so proud of. I'm personally proud of that. So how in your work are you incorporating the voices of people with lived experience? I'm going to go to Gladys first, and then to Keith, and then to Amy and Dan.
How am I incorporating their voices while working with them? Like I said, within our stipend program and my regular staff, individuals with lived experience in recovery. And we listen to what their needs are, and we try to work with them to be able to provide the services that they need. It's not always clear cut, and there's always gaps, and there's always hiccups along the way, but we try to see what their needs are.
Hi, for those of you who may not be familiar with what a recovery coach is, a recovery coach by Elliott's definition is somebody with, we ask for 2 years of sustained recovery or abstinence from a substance, and lived experience with substance use disorder and or homelessness or commercial sex trafficking. And so of course, you know, we listen to the folks that we serve, and we want, you know, treatment plans to be, or service plans to be, you know, written collaboratively based on a shared understanding of identified needs and goals and treatment preferences and all that other stuff. But recovery coaching, I think, is the best thing to happen to our field since CBT. And we have put folks with lived experience. We have a director of recovery coach services, who is the first recovery coach that Elliott hired back in 2015. And we have an assistant director. We also, at our Newland Low Threshold site and the Shattuck Cottages, they are all staffed by people in recovery. They are living, breathing personifications of what's possible. They have overcome, you know, seemingly insurmountable odds and have gotten to the other side and have climbed that proverbial mountain. And you know, without even sharing their stories with intent and purpose, you know, just their presence is you know, does work that people with dumb letters after their name like me, you know, can't do. And it's just that I can't overstate how important having the lived experience element on our leadership team. And, you know, we're not limiting lived experience to just the recovery coach role. We have people in recovery who are in case management roles as well. And, you know, we don't want to be myopic and think that everybody with lived experience is just going to be a coach and share their lived experience. And it's been huge. They have a lot of credibility with the folks that we serve.
Thanks, Keith. I can't also overemphasize how important recovery coaches are in our program. They have sort of become the leaders in transforming the way we do our services. In addition to what Keith and Gladys have both said, I want to add that we have tried multiple times and are continuing to try to have sort of an advisory board of individuals who are still actively using to help guide us in our programming. I can't say we're super successful at this. We probably don't have quite the right person leading these groups, but it is something that we try every single year, is to have a group of individuals who we run ideas by. We talk about the things we offer, So for instance, most recently, I've been asking our clients to weigh in on smoking supplies and what they would like, rather than me just ordering supplies for them, trying to get people's input. We do not have a formal advisory board, but it is something that we are always trying to do. And I think that's important for all of our programs to think about in some way, shape, or form.
Thank you. Dan?
Yeah, so when I met with Shannon back in 13, 14, I can't remember exactly when it was, she says that this person has to be in recovery. I barely knew what that was. I was new to this work. And so we decided that that's the way it was going to be. And it was not easy in the beginning back then, 8 years ago or 9 years ago, to find individuals that were, it wasn't hard to find individuals. It was hard to get to having past quarries and whatnot. So we had to work together with North Suffolk Mental Health to relax some of those. They actually sort of created an auxiliary department that wasn't really needing to, because it was also funded by the city. So we had to get creative. Otherwise, these people wouldn't have gotten these jobs, and we never would have launched. We also have input from these individuals, not just in focus interviews or we bring them in and ask them questions. We talk to people out on the street all the time. One of the things that was really incredible for us is that the same people that were giving us scowls, that were looking at us a certain way, were the same people that actually became our friends, dear friends, actually, even if they're still struggling with substance uses and those that passed away. I mean, some of them maybe never got into recovery. They became friends because we would interact with them on a daily basis, on an hourly basis sometimes. But the one interaction that I remember the most, and this is what sticks in my mind, is that when we were first thinking of the idea of the navigator and how it would work, I did ask about 15 individuals that were congregating underneath our city at our city hall, and got a lot of great input. But this one in particular individual said, I'd like for this person to, A, B, and C, to do this, be able to have do this, whatever. But the last thing he said was, he just paused and he says, maybe just somebody to talk to, somebody that I can talk to. And that's not a qualification. That was just a need for this guy. And I remember thinking, all right, that is it right there. This guy right here is just like me. He took some pills when he was younger, and now he's in a different situation. So my life really changed at that moment, and everything has been informed subsequently as a result of really that statement. It actually helped me with my family. We treated my brother's addiction as a disease versus a moral failure, and that has really changed everything.
Thank you for sharing that, Dan. So our next question is about trauma and the impact of trauma. And as we were preparing for this today, I was saying that one of the best things I heard about an understanding of trauma actually came from Keith. So I'm excited that he's here to speak to that in my career. But one other part of this question is about prevention. And as the only prevention specialist on this call, I want to say a few things. So in looking at trauma-informed practices, care, and communities, the first and foremost thing we need to do is make sure that all of our systems are trauma-informed. And ultimately, trauma-informed means that you treat everyone as though they have trauma. Because you don't know who they are, you don't know what they're going through, and some people express it and some people don't. But we treat everyone as though trauma is an indicator with them. I personally have had school officials say, yeah, I know all about trauma. I'm stressed that you're telling me about trauma. The ACEs, the adverse childhood experiences, that's really difficult for me to take on. How in my role as a school nurse am I going to deal with that? And that was an excellent pushback because it got me thinking a little bit more. Why are we leaning on our schools to raise children and not looking to support families to become out of trauma, to have those experiences in their home less impacted, right? Because we want to talk about education, we want to tell you how to be a parent, but we don't want to deal with the messiness of how hard life can be. So in the city of Medford, we're really, truly, intentionally trying to make this effort of helping people navigate services faster and better So really, again, looping the concepts of prevention into the outreach programming that we're doing. And so we're setting up an interconnected resiliency network here in the city of Medford so that if somebody in the library or at the food pantry sees someone needs a little extra help, well, let's get you to the social worker and let's look at all the factors that are going on. And what does that say to the young person in that family? That says to the young person in that family is when you're struggling, you get help. That these things are important to help yourself and to navigate through with professionals. That said, it's on our professional services that are here to help to also be trauma informed, to take the feedback that is being given to them that is negative and make changes and ensure that their staff are operating those changes and not just assuming that they are operating those changes. So that's a big job if we really want to do trauma informed work and trauma informed prevention in our communities. So that's my little grandstand about trauma, being trauma informed. So I'm going to go straight to Keith on this one. How may prior trauma impact an individual's substance use and how treatment methods account for people's trauma?
Unfortunately, trauma usually determines the trajectory of somebody's life. And since you referenced the ACE, so that's the adverse childhood events. And statistically, if you have, so the ACE is like these 10 terrible things that can happen to you during childhood, right? So it's, you know, your parents divorced, you've experienced or witnessed violence, or you've been sexually assaulted, emotionally abused, neglect, all this other stuff. If you have 6 out of 10 ACE indicators, you are 3,800% more likely to engage in IV street drug use after the age of 18 than somebody without those indicators. So, you know, how does this all like take shape? So if your childhood is spent, preoccupied with survival, where is your bandwidth to learn subjects and predicates in English class and long division and all this other stuff? So now you're, I actually personally have a visceral reaction when I hear diagnoses like conduct disorder, oppositional defiance, or anything like that, because most of the time, we're asking the wrong questions. We overemphasize the importance of diagnosing people with the right thing and pathology, as opposed to asking about what has happened to people and what is their story. And why is it so consequential that, like, is it bipolar 1 with psychotic features? Is it PTSD? Is it generalized anxiety? I'm more interested in somebody's story and what's happened to them. And the metaphor I often use with people that I serve is like, I broke my leg mountain biking one time. Imagine if I didn't go to the hospital, get it, x-rayed, put in a cast, do a logical course of physical therapy, consult with my primary care doctor. You'd never know from meeting me that at one point I was walking around with, or couldn't walk and had a broken limb. Trauma works, the same way. If it isn't appropriately treated with evidence-based, supports, then it's a lot of the person's worldview is not going to change. They're going to oftentimes wildly misinterpret the intentions of well-intentioned folks. They're going to have different perceptions than other folks. It's going to cause interpersonal strife and conflict and challenges with forging and maintaining friendships and romantic relationships. And so we, on the prevention end, at the Everett Clinic in particular, we wanted to use all sorts of evidence-based modalities of treatment to address this. So there's sensory motor arousal regulation treatment, there's attachment regulation competencies treatment, there's EMDR, all sorts of treatments that I'm trained in cognitive restructuring that stabilize that limbic system of the brain, that ferrets out what constitutes a threat. Sorry, I went long again. Go ahead.
Thank you. Actually, so we've come to a point in our presentation where we keep going and we're going to keep going we might go off the agenda. So I want to check in with MAPC about what they want us to do next. In the meantime, though, does Dan, Amy, or Gladys have any comments about addressing trauma within your work?
Yeah, I think, you know, to Keith's point that, I think every day now, everybody is doing trauma-informed care, but back in the day, it was more, why can't they stop using drugs? It was more punitive, right? And it wasn't until we, you know, Gladys attached to this, that we started to hear these people's stories. You don't need to be an expert. You don't need to go to a webinar on trauma-informed care to hear somebody's life story and not wonder why they're using drugs or alcohol. You know, some of our when we were starting to become very successful with our drug users, and that number of folks just really almost went away. To, you know, if we see a drug user out on the streets, we all flock to that person. Whereas before they were just everywhere. So what remained were these dozens of Hispanic alcoholic men, predominantly from Central America, some of which had experienced severe trauma. I remember one time, and people would say, "Good luck helping them. They're never gonna listen." And that is not true. But just a quick story about them. They were talking about how some of them were balseros, and a balsero in Spanish and English means bagger. And so back, you know, during these conflicts, people would get murdered, and these guys would come in and put bags in the bodies. And you wonder, you know, why this person's drinking alcohol, right? So I think us learning people's stories and not that we would talk about those things with them all the time, but just being more empathetic. We were able to be more successful in our attempts for them to get the help that they needed.
Thank you so much. Okay, so I have one final question. We're going to do this one because I think of the 144 participants here, most of you are probably from municipalities, I think. So in terms of how do we fund? So there's two questions here. I think we can smush them together, and I'm going to just actually direct this question only to Dan and say one thing from me. So the two questions are, what things do you want to do but can't because of lack of funding or resources? And then the other question is, how do you approach obtaining funding? So I'm hoping you can wrap that in. I'm going to answer this a little bit. Effectively, I'm running a small nonprofit out of the city of Medford. I have multiple grants and multiple funders and multiple people to answer to. That's not ideal. It's a waste of a lot of time that could be out working directly with people. I've somehow become a master at it, but that is what it is. That's what I've had to do. Every time there was a barrier, I said, I'm not stopping. We have to keep going. And we found the funding to fill in that gap. So that's what we've done in the city of Medford. I'm going to turn it to you, Dan. You're going to finish this conversation, and then we're going to step back and let MAPC take back control.
Yeah, so I'm going to answer this in a little bit of a roundabout way. So initially, we had to struggle with that funding from the city council. They did not want to fund the idea of two people that were going to go help people that were from different communities. One councilor even asked, why don't we build the other cities of the people that were here, which is obviously ridiculous, but that's how frustrated they were. And so when we got that initial funding, that created the success, which then they drove to get the CAPIC funding, right? So you can see the success beginning success, right? And so when it's almost like there's a fire and somebody goes to help, and then more people come to help, even before the first responders get there. And then all of a sudden you're triaging the situation and everybody's chipping in. That's what started to happen. Well, we could do this, we can do that, we can have people have more access to our services. And then the last people really to respond are sometimes the municipalities. And so the municipality we're saying, okay, we need to expand our services, right? Everybody wants the back winner. So you first have to get over that initial hump and kind of have a small success story, right? And so then we started to meet people like Keith Wales. We don't need to generate funds. We just need to find people like Keith, who has helped us over and over and over and over again house individuals and to support them. So it's not just that we need to raise funds. We need to access people that have resources that we need that typically cost money that you do not have. We are a resource magnet in Chelsea. I think we've gone to 0 to 100, to be quite frank. We're not even thinking about raising funds all the time. We're thinking about how can we better connect the people that are doing the same work together, because people go from one city to another, right? And that is what has been really, really successful for everyone. I just want to
Great,
quickly point out that there's people in Pittsfield, North Adams, there's hubs there. So if anybody wants to reach out to me, asking for services, that you may not be aware that we have hub situation tables, 20 of them in the state. So if anybody I'll put my number in the chat box. If anybody wants to reach out, how they can access people that are doing this work, I'd be happy to help.
Yeah, I think, Dan, I just want to like really hammer home that we have in the city of Medford, we've tapped into the lead that Dan has created around hubs in Massachusetts. And it is absolutely necessary because these nonprofits and these people who do the helping work, they got a lot of work to do. They got a high degree of burnout. And if we as municipalities can create efficiency for our nonprofits to serve our populations, we're going to do better overall for everyone. And Dan really is the forethinker and the leader in this. And I want to thank you for the mentorship you've given me. And I want to encourage you to reach out to Dan as well. So we have some questions in the chat. So to everyone on the panel, how do you engage the community to gain support for housing and harm reduction services?
Can I take this one?
Yeah.
Well, just because it's fresh on my mind, the city of Lynn has been an absolute pleasure to collaborate with on this new BSAS funded low threshold site. It's been a true community effort. I mean, the city, I'll just tell a quick funny story to illustrate this. The developer texted me, "Hi, some of the neighbors are saying that there's quite a bit of police activity. Can you look into this?" And I sent him back a text message with a picture with the Lynn police trimming the Christmas tree with our clients. And I said, that's because they are partners with us. And I got a big thumbs up emoji. And the police, if they see some of our folks, we took, I should also say, we took 24 people who are living behind the Walmart in Lynn and a cemetery and the train station. We partnered with the Lynn police, and we have jail diversion clinicians who are embedded and integrated into the Lynn Police Department. And we, identified and housed these 24 folks at the beginning of December. We are studying the impact of, 911 calls. A lot of these folks were daily, presentations at Salem Hospital, and we've only had 3 911 calls in 2 months, and 2 of them were medical for chest pains. And we have, Healthy Streets comes and does and collaborates with our recovery coaches. We have on-site methadone. The police have been helping our folks engage with the STAR program about vocational opportunities. The Lynn Community Health Center does on-site primary care, dental clinics, and wound care, and partnered with us to get visiting nurses for folks. And my brother's table, we had a 2 or 3 day delay on getting folks into the place just because of getting some inspectional pieces addressed at the site. My brother's table went to the hotel where we put folks and brought them meals. I mean, it has just been this wonderful community that's wrapped themselves around this project over the last 2 months, and it's been an honor to partner with them on this.
Anyone else have something to share on this question?
Gladys can touch on this. I'll start, Gladys, and you can finish. So one of the first things that we did was, well, we do a lot of housing now, but one of the first things that we did was open up a resource center that's not welcomed by the community at the beginning, because a lot of people were congregating outside, and there was just problems all around that neighborhood, which had historically not seen too many problems, right, in the part of Chelsea that it was. So we had to work directly with not only the community, but also with the people there. We were basically saying, look at all the great things that you're getting, and let's all be responsible So basically, in a kind way, saying, don't mess this up, right? And they started to self-police each other. They're the ones that were starting to usher people back into the center versus loitering out in the street. You know, we started to clean up around the area. So we had a partner, not only with the community, we had a partner with the people that were getting help. And then we brought in Catholic to manage that effort because it needed management. It was a church pastor who was opening up his doors for that. The other part that also want Gladys to talk about is the COC. We did not know anything about housing, and we learned about it, and we have housed a ton of people. Even before we met the great Keith Wales, we housed a ton of people. Then when we got with Keith, it just blew up. So Gladys, if you can just talk a little bit about that.
Yes, so first, with the church, that was a community effort and opening the doors to individuals who had no place, like I said previously, to go and get a warm meal, breakfast and lunch, or even a hot shower. That opened a lot of doors for these individuals to be able to at least come in there, share, and also share their stories, because we've learned a lot from being there at the church. But it was a community effort. And like Keith was saying about Lynn, that is awesome. And that's how we have a community here in Chelsea. We all work together. We all have each other's numbers. We have a Slack channel, and we're able to connect with, the police, the navigators, etc. As for the COC, we started helping individuals with those applications, and it's coordinated care through DHCD. And we were able to assist in housing multiple individuals that were out on the streets. At first, it was a struggle for some of them because they had been on the streets for so long that, for example, one particular person, she had been sleeping on the streets for so long that she didn't even know what to do when she got her one-bedroom apartment. It was kind of sad in a way, because when we were able to get her a bed and so forth, and we helped, my staff and I helped set up everything for her, and we noticed, we went back to bring her, a couple of days later, we went back to bring her some utensils and dishes and whatnot. And we saw that there was like sheets on the floor, etc. And in conversation, I said to her, do you need more sheets, or is there a problem with the bed? And she's like, no, I'm just so used to sleeping on the floor that it's taken me some time to actually want to get on this bed. So we had to give her time, and within time she called us and she was like, I just wanted to let you know that I finally made it to the bed. So we've helped other individuals that were like running out on the streets and didn't want anything to do with us at first. And once we got to sit and have a conversation and listen to their stories, and we built this trust with them, we're able to help fill these applications with them and eventually get the calls that they were looking for them for additional information. And we even helped with our truck, help move them from, whatever storage area they had, their items, and move them into single. It started with single rooms, and then from there, they eventually got one-bedroom apartments. But there are still some communities that are working, like Dan likes to say, in their own little silos, and they still have a hard time connecting. And these are cities that surround us, and it's difficult because we're trying to help individuals within their city, but it's like their police departments or their city government just doesn't quite get it. So hopefully that Dan keeps trying to get them to get hubs. So we're working on that.
Yeah, they come to us. The residents come to us.
Yeah, correct.
Thank you. So Amy, I want to ask the question. So how do you engage the community to gain the support for the work, the harm reduction service and the housing? So that's great. Thank you.
So I'd love to kind of share our experience. And there have been moments where the collaboration has been fantastic, and there have been moments when the collaboration hasn't been. And so I want to kind of paint maybe a slightly more realistic picture for some communities where it's challenging to work together. A couple of lessons we've learned. First of all, we're in this for the long haul. And this is a long game. Addiction is going to be with us. And so I think that's just sort of my first take home point is stick with this. We don't give up. We keep trying. With every change of leadership, we have to re-engage leadership in what we're doing. Sometimes we've done that successfully, and sometimes we actually have not been very successful at it. I will tell you some of the kind of lessons we've learned. As a scientist, I tend to approach these things through a scientific lens and talk to mayors and city leaders with scientific evidence that harm reduction does not increase crime. Harm reduction saves lives. Harm reduction is good for the city, and have been told I'm not interested in hearing your story because it's not speaking the same language. And so we've really had to learn how to speak the language of the person we're talking to. Not to say that our leaders are not scientific and not intelligent. It's just that they have perhaps a different value system. And so I have to try to understand the person I'm talking to, what is important to them. What are their needs? What's on their desk every day, and how can I communicate with them? So that's a lesson that I am constantly learning. Secondly, I think there is nothing quite like serving somebody to gain their trust. For city leaders to accept, particularly things as radical as or what they might think as radical as a harm reduction site, such as a syringe service program. I need to serve our community. Our organizations need to serve them so that they trust us. It's not going to work without trust. And so my team is out on the streets every single day picking up needles regardless of the weather. And we are serving, we are picking up trash. We are doing things that are outside of our scope so that we can show our municipalities that we care about the individuals, those who inject drugs and those who don't inject drugs, those who are homeless, those who are not homeless, the children, the adults. We care about the community and we want to serve. So thinking of this in the long term, serving to build trust, and then learning to listen and speak in the language that somebody and with the values that somebody cares about, I think are the three things that I've learned in the last few years.
Amy, I was going to say almost the same thing. I need to know everybody's job to understand why they understand what we're trying to do. I appreciate everything you said, and going above and beyond and showing that we're invested in the community. Absolutely beautiful answer. I hope everybody was listening or go back and watch the recording. Okay, so the next question I have is what are the best options for youth who are experiencing substance use disorders under 18? What services are available? How can we help them navigate these barriers to getting help or to getting treatment? And also, if anybody has any, maybe Keith, if you have any information about the experience of youth in such treatment, might be helpful too. But anyway, we'll start there. So what are the options for youth who have substance use disorders? Whoever wants to chime in first, feel free.
These are our navigators don't find 15-year-old kids out on the street using drugs. What happens is typically a situation is brought forth to the hub of this 15-year-old kid who's not going to school or using drugs and hanging out with the wrong crowd and recently got arrested by the police for this or for that. So it's not that we're only going to go and offer treatment services for this individual. But we're going to wrap around this individual and find out what are the root causes of why this person is doing this. It could be that this person just got reunited with his mother who he hadn't seen since he was 2 years old, and she has a new husband and 2 new kids, and don't mess this up, right? So now this kid is turning to other supports, and maybe there's some marijuana use that might lead to other kinds of use. So we work with the mental health component of that. Why this kid is in this way, and then there are treatment services. Our navigators are familiar with all the under 18 services that are available. Usually DCF is involved, and so we all work together to make sure this kid gets out of harm's way, and we have pretty good success with that because we're able to nip things in the bud early on, in the process of this kid. So it's not just Oh, I know this treatment facility that is for under 18, and let's get them there because we're likely not going to be successful. Unless, I'm sorry, unless you look at the underlying conflict.
Anyone else?
I would just say that the treatment options for adults are the same, work really well for adolescents. And so from a treatment perspective, I think getting an individual into medical treatment for substance use should still be one of the first things that we do. Medications work great, and clinicians are able to treat adolescents.
Thank you. I think as a part of the current wave of prevention in the state of Massachusetts, looking at health equity, looking at some of the harms that have been done to young people and to adults around, cannabis use and, being jailed for that. We're looking at all of this in this very complex state. And to think about how are we incorporating harm reduction with young people? That doesn't sound right. That doesn't feel right. But it's working with adults. So that's the other component here too, right? Is that we're really meeting the young user where they're at and really helping them to create a wellness plan for themselves, right? Again, personal empowerment and intention to make changes. That's a part of the recovery coaching process. And I think it's a similar thing that should be happening with youth. And I think communities at large should start thinking about this, right? And thinking about how we can do this safely, because really no substance use free youth is safe. Their brains are developing, right? They're growing into these adults, but they are living a reality that we have to be honest about, that these substances are providing a coping mechanism for something that's going on with them right now, period. So what are we going to do as a workforce in prevention? And how can we, again, put these concepts into one package and make an impact for our people in the state of Massachusetts? So the next question was actually directed at me, which that's not what this was about, but how does Medford weave prevention and outreach? This is how we do it. They have very different kind of right? There's some very different pieces to it, but really what I've been doing is taking the method of prevention. Prevention is a science. It's not a program. It's not an assembly. As a matter of fact, don't do an assembly and call it a prevention practice. It's not. It's a component that can help an overall strategy, right? So I've been using all the lessons that I've learned from my mentors, like Tracy Destovich, who's on this call. That logic modeling is how we set intentional plans for our community on our outreach work, right? Making sure that collaborations and conversations across key stakeholders are critical to developing and to implementing what we're doing. And those key stakeholders include people with lived experience, which we've already talked about. But really what I'm saying is science, prevention is a science, it's a process, and it's long-term planning, just like your community development office does planning for their, master plan. We need to do these plans for behavioral health. I've pulled back on just focusing on youth substance use, and I've really turned it to be behavioral health. So in the city of Medford, we have a Promote, Prevent, Support Behavioral Health Commission that was established over the last 2 years. And we're just getting started and we're growing. But the purpose of it is so that at every phase of what we're doing, promotion, prevention, and support, that we're utilizing the mechanism of being grounded in data, being communicative with each other and with the community, and inviting people with lived experience to speak up and be a part of the community's change and efforts. And really, at this commission, and again, I'm just highlighting this commission, it's not the savior of whatever we're doing in Medford, it's a component of it. But the purpose is that the people who have been assigned to this commission are top officials in each of our departments in our city. And the purpose is they make budget decisions. So often you're on a coalition and the person that's sent to be representing the police department or school department, they're very low in the chain of command. And then they themselves are being tasked to go back and advocate up. That's a difficult thing to do when you're in a subjugate position within your organization. So the intention here is that the police chief and the superintendent are hearing the exact same information, right? And that with our behavioral health outreach, again, it's much broader than substance use. We have concerns about elder mental health, hoarding, again, homelessness is emerging in Medford. That's new for us, right? So we're trying to get this large perspective and get everybody invested in the practice of prevention and applying it to each of their workspaces, right? Assess, capacity building, planning, implementation, evaluation, cultural competency, sustainability. How, when we start this plan, are we sustaining this plan? That's what we've been doing in Medford. Sorry, the other thing I would suggest is always talk with conviction. People listen. Or they think you're a jerk, but that's what they do. They do listen when you advocate strong for people. So the next question, what are opportunities to address regional substance use regionally? I'll let anyone take that away.
Yeah, I think the reason why Penny and I have such a good relationship, as well as Paul, both Pauls and Revere and Malden, is because we were actually brought together as part of the RISE, RIZE, the organization that's looking to do something about the opioid crisis. So we came together from a regional perspective, but the other city that's next door to us, we don't have that relationship, and as a result, it's not hunky-dory as it is with the other communities. So we're trying to work around that. We're trying to work through that. So it's really important for you to partner with the agent with the cities around you, because people will go from one city to another, and it can create frustration. Oh, we just got somebody from so and so, or the police department just dropped somebody off, and sometimes that's true, sometimes that's not. So it's really important to do that. But just going back a little bit about the municipality perspective on this work. Most communities have coalitions, and their coalitions are designed to do something about the drug problem, right? And it's important to understand that a lot of these coalitions are just coming up with ideas and what can we do and what are the problems and let's hear stories. Nothing against that, but there's a big difference with that and other coalitions or other working groups that are going out into people's homes and doing the work. So I live in Braintree, and there was some friction there because there was a misunderstanding between somebody who had just lost somebody because of an overdose with that group, because he felt that group hadn't done enough to help his kid, and it wasn't that group's role to do that. So there's that's really important, because you got to have an understanding of that, and then maybe from within that coalition you can create an intervention team, whether it's doing something like the hub or hiring navigators, but you need to have interveners. If you don't have interveners, you're going to continue to have that misunderstanding.
Okay, I'm going to move to our final question. What is one thing you want people to walk away from this session knowing or thinking about? Just a few minutes for each of us, a minute or two, each of you, to say what's your final burning thoughts. Mine is, these are not separate issues. These prevention and outreach, prevention and recovery, they are not separate, they are together. We're looking at the holistic approach and understanding it on multiple levels, right? Multiple layers. So that's my personal one. And then we'll go around the room. So why don't we go to Amy, Keith, Gladys, and then Dan.
Sure. I'm going to steal an idea from one of my favorite TED Talks, which is that the opposite of addiction is not sobriety, it's connection. And I think as we think about prevention and as we think about treatment and housing and all of the things we're doing, it is connecting with people. Loneliness kills, but if we can improve opportunities for people to connect on really deep levels, I think we will start to change the scope of this epidemic.
I'd like to close with, I have a statewide role, and where we have been the most impactful are communities where there's a champion. You know, there's a Dan Cortez, there's a Penny, there's a Gladys, there's an Amy, and the importance of cultivating that trust. You know, when I worked in the city of Everett for 8 years, I didn't just march into the mayor's office and ask for 5,000 square feet of space to start a family resource center for a nominal amount of money. We started with $10,000 grant that Cambridge Health Alliance gave us to do a DBT art expressive group with. And over, time and cultivating that trust that Amy referred to, it ballooned into a contract with 15 clinicians providing human service work. And together collaboratively, we decreased the out-of-school suspension rate by 20% in 1 year, in the first year. And that was infusing evidence-based practices, but also truly partnering with the community on a lot of different initiatives. And that's where the work gets the most impactful, is when you have those collaborative champions working with people. Anyway, yeah.
Gladys and then Dan.
The importance of the connections, prevention, and the trust of the community. Not just the individuals we're working with, but the community in a whole.
Yeah, agree with Keith and Amy, obviously and Gladys too. Connection is huge. I'm a big believer that connection there's no cure for addiction, but as close to a cure for addiction as there is. My brother had all the resources that he had in Arizona, the same resources in Arizona, but they were disconnected, right? Go here, go there, you gotta do this, you gotta do that. He came to Arizona and it was almost like a NASCAR coming to pit. Everybody's helping him. Everybody's coming to the car in a timely manner. And that's what Gladys did. That's what the Navigators did when my brother first landed in Arizona. And he still struggles, but he's alive. I thought he'd be dead by now. And so in addition to sort of like, where do I start? Like when you look out of an area, like for example, Madison Castle, you see a boatload of people, where do I start? And then you start thinking, what solution can I have that's going to fix this problem? Well, you're not, there's no solution that's going to fix this problem, but there is a solution that's going to fix his problem or her problem. And when you do that, then you start to see those numbers dwindle. And I can say that because that's what happened in Chelsea. We didn't have a fell swoop, a plan that was going to take care of everything. We had a plan that was going to take care of one individual at a time. And then just to wrap up, we went from a community where if you saw somebody passed out on the sidewalk, people just walked over that person or around that person. One time I saw an individual just walk into a doorway a little bit on Broadway, and all of a sudden I saw urine coming down the sidewalk and people just walked around it or walked over it, right? It went from that to, I get a call from a resident because half the city has my number. You gotta be willing to give your number out. Damn, there's a lady passed out at the bus stop under the bridge, and you better send a navigator. So sure enough, I sent a navigator. The navigator goes, a few minutes later calls me up. Dan, it's a young college student. She's on her way to Bunker Hill. She was just sleeping on the bench until the bus came. So we went from a community that walked over people that may have been dead to, Dan, there's somebody that needs help, because they know that help is there. But that didn't happen overnight. That took years, and you got to start with one person.
Well, hey, thank you. Thank you to our wonderful panel. That was really great. I'm sure we could have spent another hour, hearing about the great work you do. I guess, it was really nice to sum it up on the themes you touched upon, and really talking about what it takes to provide care, support, and build trust with individuals suffering from SUDS, and how important, it's not just about treatment. Treatment is important, but it is also about all those, life recovery and connections and building, pathways for people to get back into the community. So that was really awesome. This is our second of 3 webinars, as I said at the top. Our next one is March 8th at the same time, 9:30. And if you had registered for this one, you will have the information for the next one as well. So this was really great. I just want to thank Penny for doing an amazing job moderating, and all our panelists for sharing such wonderful insights I learned a lot, and I hope everyone else did. I would say one last thing, in the chat, there were some things, placed there, connections in names and numbers and a few links. And we can try to make that available to people as well if they didn't get it in the chat. So thank you to everyone, and we will see you back on March 8th.